Welcome to the deep dive. Today, we're tackling a really critical area in emergency medicine and intensive care. When a patient comes in with just this confusing mix of symptoms, how often do we think, could this be heavy metal poisoning? We'll be pulling apart a recent review that really zeroes in on managing intoxication from 5 common toxic heavy metals. We're talking mercury, lead, chromium, cadmium, and arsenic. It's kind of sobering when you think about all the ways we can be exposed and the serious problems they cause.
Absolutely. And what jumps out at me is this dual threat. The review points out some exposures are accidental, maybe environmental, but others come from industry or even things people buy, consumer products. So recognizing these poisonings, well, it means you need a really broad awareness of where they come from and how they actually mess with the body.
Precisely. So our goal today is to give you, our listeners in critical care, those key insights. We're focusing on clinical suspicion about what are those early signs, those red flags that should make you think heavy metal. Then how do we actually confirm it quickly? And finally, the treatment. What are the essential strategies, especially anything new that might be relevant right now in the acute setting? Chelation therapy has been the standard for years, yeah. But it's interesting to see the research exploring other options, too.
Definitely. Like complementary therapies.
Okay, let's dive in. First up, mercury.
Right. Mercury. It's a real diagnostic challenge, as the review says. It looks so different depending on the type of mercury, how you were exposed.
Yeah.
Human activity, anthropogenic emissions have spread it everywhere globally. It gets into the food chain, builds up in fish. That's a major route for methylmercury. MeHg, we can call it.
MeHg, got it.
But there are other sources, too. The review highlights these. Industrial uses, sure, but also dental fillings, even some skin lightening creams containing inorganic mercury. And a core mechanism, you'll see this again, is oxidative stress. Basically, things get out of balance at the cellular level.
So for a doctor in the ED or ICU, when should mercury pop into your head? The review gives some good pointers for acute poisoning. Say someone inhaled mercury vapor, maybe an industrial accident, thick sudden fever, shortness of breath, chills, that weird metallic taste, pleuritic chest pain too, that sharp breathing pain, that's a key one. And it can quickly go downhill, confusion, lethargy, vomiting, serious lung issues.
Yeah, and if they swallowed inorganic mercury salts, that's often much more severe, very corrosive. You might see that ashen gray look in the mouth, bloody diarrhea, intense abdominal pain, lots of vomiting. That can lead to hypovolemic shock, a dangerous drop in blood pressure. Also look for inflamed mucous membranes, maybe gum irritation, kidney tubule damage.
And that metallic taste again.
That metallic taste again, yeah. And even loose teeth sometimes.
What about chronic poisoning?
Chronic is more often from organic mercury, like that MeHg from fish over time. But it can also develop slowly from occupational exposure to elemental mercury. Initially, it's vague, right? Loss of appetite, weight loss, fatigue, muscle weakness, non-specific stuff. But over time, the central nervous system and kidneys often take the biggest hit. So clinicians should look for tremors, often starting in the face, eyelids, limbs, and psychological changes. Irritability, anxiety, shyness, loss of confidence.
And the kidneys.
Kidneys, yeah. Protein in the urine is common, indicating glomerular damage. It can even progress to full-blown nephrotic syndrome.
Okay, so suspicion is high. How do we nail down the diagnosis in a critically ill patient?
Well, the review emphasizes getting a really detailed history. You have to ask about work, diet, any unusual products they use.
Yeah.
Dig deep. Then, measuring blood mercury levels is key for recent exposure. Hair analysis can give a picture of longer-term chronic exposure, especially to MeHg.
So it's putting the pieces together, symptoms, history, potential exposure, lab tests.
Exactly. It's detective work.
And treatment for acute mercury.
First step, always get the patient away from the source. Then basic support respiratory, cardiovascular, ABCs. Chelation therapy, using drugs to bind the metal, is generally for symptomatic patients with acute inorganic or metallic mercury poisoning. Agents like BAL, D-penicillamine, DMPS, succimer get mentioned, though the evidence for how well they work in the really, really severe cases is still a bit limited.
Right, and there's a really important point about BL, isn't there?
Crucial point. BAL should not be used for methylmercury poisoning. It can actually make things worse, potentially redistributing mercury to the brain.
Good reminder. Are there newer things being looked at?
Yeah, the review touches on some interesting research. There's Shenkang, a traditional Chinese medicine, being studied for mercury-related kidney issues. Things like calcium carbonate, garlic, yes, common garlic, and N-acetyl-cysteine, or NAC, show some promise. Selenium is interesting too. It might help redistribute mercury and boost removal. Alpha-lipoic acid is another one that chelates mercury and can cross into the brain. And flavonoids, like myrcetin, might protect against organ damage.
Okay, let's shift gears. Lead.
Lead. Okay, exposure routes here are mainly ingestion, inhalation, or sometimes direct skin or eye contact. Historically, lead paint, leaded gasoline were huge sources. Now it's more occupational exposure and, worryingly, things like adulterated opium in some regions.
Adulterated opium. Wow.
Yeah, it's a reported source. And like mercury, lead toxicity involves oxidative stress and inflammation.
So in critical care, what does acute lead poisoning look like? It's rare, you said.
Very rare, but can be severe. Think high vapor inhalation, maybe industry, or swallowing a large amount. You might see severe abdominal pain, hemolytic anemia where red cells break down liver, and pancreas inflammation, even brain effects, encephalopathy. The fumes are inhaled, cough, headache, confusion, drowsiness, that metallic taste again, possibly seizures or unconsciousness. Eye contact usually causes conjunctivitis.
But chronic is more common.
Much more common. Yeah. And often insidious, developing slowly. The review calls it a silent disease. It hits multiple systems: nerves, gut, blood, kidneys, heart. And critically important for children. There's just no safe blood lead level. It has lasting effects on their developing brains.
The review breaks down severity by blood lead concentration, or BLC. That seems useful.
Yeah, it gives you a framework. Mild, maybe 20-69 micrograms per deciliter, often has non-specific CNS stuff. Mood swings, tiredness, irritability. Moderate, say 70-100, you see more CNS and peripheral nerve issues. Headache, memory loss, plus GI problems like abdominal pain, constipation. Severe, over 100, is thankfully rare in adults. But that's when you can see encephalopathy with seizures, confusion, nerve damage, anemia, that classic colicky abdominal pain, kidney problems, even heart rhythm issues.
Confirmation sounds similar history and the blood lead level.
Exactly. Detailed medical and exposure history, plus the BLC measurement.
And treatment. Starts with removing the source.
Always stop the exposure. Then, for symptomatic patients, chelation therapy. The choice depends on severity. The BLC, the individual patient. Succimer is the one FDA-approved chelator for kids with BLCs over 45. Dimercaprol and canatinib are also used. D-penicillamine, less so now because of side effects.
What about lower levels, say 2044 on GDL?
Yeah, interestingly, the review points out there's no proven benefit for chelation in that range.
And recent research. Any new angles?
People are looking at different chelation regimens, maybe combining them or using natural substances alongside. There was that study mentioned comparing D-penicillamine plus garlic to succimer, similar results, but the garlic combo was cheaper. And animal studies show promise for antioxidants like moringa oleifera extracts, vitamin C, silibinin, milk thistle, garlic again, reducing oxidative stress and lead levels, probiotics too.
Fascinating. Okay, next up, chromium.
Chromium. Big industrial uses plating, steel, pigments, tanning. Exposure is mainly occupational or environmental. And the key thing here is valence state. Hexavalent chromium, Cr6 plus tennis white, is much more toxic than trivalent, Cr3 plus Dan.
And toxicity mechanism.
Oxidative stress again, that's a recurring pattern.
Acute poisoning from Cr6 plus sounds pretty bad.
It can be incredibly severe if ingested. It's highly corrosive. Think intense nausea, vomiting, diarrhea, GI bleeding, fever, cramps, DIC, acute kidney injury, metabolic acidosis, liver damage, multi-organ failure, coma, death. Inhalation can cause ARDS, heart problems, and skin contact with Cr6 plus solutions can cause these deep ulcers, chrome holes.
Chronic exposure.
Chronic inhalation hits the respiratory tract hard,
Correct.
irritation, inflammation, nasal septum perforation, chronic cough, asthma, increased lung and nasal cancer risk. Skin contact leads to those ulcers or allergic dermatitis. Cement workers are prone to that. Even taking too many Cr3 plus supplements has caused problems in some reports: weight loss, anemia, liver, and kidney issues.
Prognosis for acute Cr6 plus ingestion sounds grim.
Often very poor, yeah. High fatality risk. Treatment is mostly supportive care because
the usual chelators don't work well?
Exactly.
Yeah.
Little evidence they help with chromium.
So diagnosis in the critical setting relies heavily on history and recognizing that severe symptom cluster.
Pretty much. A good medical and occupational history is vital. Researchers are looking at biomarkers, but clinically it's about suspicion based on presentation and potential exposure.
Treatment then is mainly supportive.
Basic life support, ABCs. Decontamination for skin contact, soap and water for Cr3 plus filari. Maybe gastric lavage for recent large Cr6 plus ingestion if no major esophageal injury, but activated charcoal doesn't bind chromium, and dialysis if the kidneys fail. But again, no effective chelator is approved.
But there are some potential newer approaches.
Some exploration, yes.
Yeah.
NSE, N-acetylcysteine, comes up again. It's an antioxidant, might help excrete chromium, maybe convert CR6 plus to the less toxic CR3 plus Charky. Some case reports suggest NSE, maybe with vitamin C, could be beneficial in severe exposures. Animal studies also hint at benefits from selenium, melatonin, resveratrol, alpha-tocopherol, mostly by tackling that oxidative stress.
Okay, fourth on our list, cadmium.
Cadmium. Exposure routes are air, water, soil, food. Industrial emissions are a big source: mining, smelting, batteries, fossil fuels. And tobacco smoke is a major contributor, actually. Absorption through the lungs from smoking is higher than from the gut.
Wow, didn't realize it was so high from smoking.
Yeah, significant source. Cadmium likes to accumulate in the kidneys, so nephrotoxicity is a major concern with chronic exposure.
What about acute cadmium poisoning?
Usually from inhaling cadmium oxide fumes, like in an industrial fire or smelting. Symptoms often start 6-12 hours later: cough, fever, respiratory distress. Can rapidly progress to severe lung injury, hypoxia, even death. A key point is the initial presentation might seem deceptively mild. Acute ingestion looks more like standard food poisoning.
And chronic. You mentioned the kidney.
Yes, kidney toxicity is primary. Proteinuria is a key sign, often irreversible once it starts. Can lead to glomerular dysfunction, calcium loss, tubular problems. Chronic inhalation can also contribute to lung issues like COPD and emphysema, and it affects bones osteomalacia, increased fracture risk. Remember the Itai disease in Japan? That was cadmium. Plus, cadmium is a group 1 carcinogen, definite link to lung cancer, possible links to others.
Prognosis depends on exposure.
Right. Route, dose, duration. Severe acute inhalation can be fatal. Chronic effects are widespread. Early detection of kidney issues might allow some recovery, but severe lung inflammation needs aggressive treatment.
Diagnosis involves history, blood urine levels, and kidney markers.
Exactly. Thorough history, measure cadmium in blood and urine, and check for those markers of renal tubular dysfunction, like beta-2 microglobulin.
Treatment for acute cadmium.
Supportive care is key, especially for the lungs, maybe gastric lavage if ingested recently, corticosteroids for lung inflammation, hemodialysis if kidneys fail, but again, that doesn't really remove the cadmium itself.
And chelation for cadmium.
Benefit is unproven in acute ingestion. Some suggestion succimer might reduce gut absorption and improve survival, maybe DMPS or DTPA. But BAL is definitely contraindicated. It forms a complex with cadmium that's even more toxic to the kidneys.
So avoid BAL. Any recent research highlights?
Focus is often on natural antioxidants, again, curcumin, ginger, resveratrol, royal jelly, spirulina, NAC. Some dithiocarbamate derivatives look promising for increasing excretion in animal models. Probiotics might reduce absorption, and essential trace elements like zinc and selenium could offer protection.
Okay, last one on the list, arsenic.
Arsenic, found naturally, but also used industrially. Big concern in contaminated drinking water in many parts of the world. EPA WHO safe level is less than 10 parts per billion in water. Prevention is key: safe water, soil remediation. Even how you cook rice can make a difference. Nutritional status matters too. Selenium, zinc, folate might be protective. And yes, oxidative damage is a major mechanism here as well.
Acute arsenic poisoning. Sounds nasty.
It can be very severe, especially from arsenic trioxide. Often rapid onset gastroenteritis, intense nausea, vomiting, diarrhea, sometimes bloody cholera-like, abdominal pain, sometimes a garlic odor on the breath, severe thirst, dehydration leading to low blood pressure. ECG changes are common. Prolonged QT intervals is a big one. Risk of arrhythmias. Neurologic symptoms too: delirium, seizures. Plus lung, kidney, liver damage, blood count problems.
And arsine gas.
Arsine gas is extremely toxic. Inhalation causes massive rapid hemolysis, destruction of red blood cells. Leads to kidney failure very quickly, often within hours to a day. Port wine-colored urine is characteristic. Very high fatality rate.
What about subacute or chronic?
Subacute, maybe weeks after an acute event, often shows neurological signs: sensory neuropathy, weakness, plus blood issues, cardiovascular problems. Chronic arsenicosis is multisystem. Classic skin changes: hyperpigmentation like raindrops, thickening on palm soles called hyperkeratosis, white lines on nails called Mies lines. Also peripheral neuropathy, hearing loss, cardiovascular disease including black foot disease, GI problems, liver damage, blood disorders. And it's a group 1 carcinogen: skin, kidney, bladder, liver, lung cancer risk increases.
Prognosis sounds highly variable.
Highly. Depends on severity. Acute death is often from shock or cardiovascular collapse. Survivors frequently have lasting nerve damage. Chronic recovery is slow, often incomplete.
Diagnosis. History again.
History is key: water source, occupation, diet, even recent shellfish are acute cases. Urine arsenic levels are the main diagnostic tool, especially a 24-hour collection. Goal is usually less than 50 micrograms per liter after chelation. Hair samples show past exposure, but aren't precise about timing or route. Blood levels drop fast, so not as reliable.
Treatment for acute arsenic.
Aggressive fluids and electrolytes are crucial, but carefully watching for fluid overload. Gut decontamination is controversial. Maybe bowel irrigation if you see it on X-ray. Hemodialysis if the kidneys fail. Chelation with agents like succimer, BAL, or DMPS is most effective if started very early.
And for arson gas.
No specific antidote. Supportive care is everything. Manage kidney failure, maybe transfusions for the hemolysis, possibly exchange transfusion in severe cases.
What about chronic arsenicosis?
Primarily symptomatic treatment. Stop the exposure, find and eliminate the source, like contaminated water. Chelation has limited effectiveness in chronic cases. Succimer is often preferred if used.
Any new developments in arsenic treatment?
Research continues. MeHg, a modified succimer, showed promise in animal models, now in early human trials. Lots of interest in antioxidants. NAC, melatonin, green tea extract, various plant compounds showing protective effects in lab or animal studies. Vitamins, minerals like zinc and selenium, folate might help. Some think combining phytochemicals with chelators could be synergistic, or maybe nutritional therapy is better than chelation alone for chronic exposure, but we need more clinical data.
Okay, let's zoom out. Looking across all 5 metals, the review mentions some similar initial steps, like maybe gastric lavage early on.
Yeah, and some acute ingestions, if caught very early. But then you have specific concerns for each metal brain edema and lead, hemolysis and arsenic, those skin burns and chromium.
And chelation is the main antidote strategy, but research continues.
Exactly. Chelators bind the metal, help you excrete it, usually in urine. That's the idea. But they have risks, potential kidney toxicity, electrolyte problems. They might not pull metal out from inside cells effectively. You can lose essential minerals. And sometimes they even redistribute the metal to other organs.
Yes, which is why people are looking for better options or combinations.
Right. Safer chelators are combining them with antioxidants or other compounds, using natural things with similar properties, like garlic containing thiol groups, lots of animal studies on compounds with antioxidant, anti-inflammatory effects, phenolic compounds, flavonoids from fruits, herbal medicines, even looking at nanoformulations.
The review summarizes the main chelators for each, Table 3. Let's quickly recap the key points. Mercury. No single best antidote. BAL is a no-go for organic mercury. Succimer possible.
Lead. Succimer is FDA approved for kids. Dimercaprol before Cana-2-EDTA.
Chromium. Chelation unproven acutely. Succimer DMPS DTPA maybe. BAL makes kidney damage worse.
Arsenic. Chelation best early acutely. Succimer, BAL, DMPS. Less effective chronically. Maybe nutrition combo is better. No antidote for arson gas. Dimercaprol possible, succimer possible.
And sometimes different approaches give similar results, like that D-penicillamine plus garlic versus succimer for lead study. Cost and availability matter. And those phytochemicals like curcumin, quercetin, potential helpers.
Potentially. They fight free radicals, might boost chelation. Animal studies look promising, like quercetin with DMSA for arsenic or with allicin for lead, but mostly lack human trial data. Could be adjuncts down the road.
So, wrapping up this deep dive, it seems clear chelation is still central for treating toxic heavy metal poisoning.
It is, though less toxic options like succimer and DMPS are definitely gaining ground.
And the research focus is shifting towards combinations, maybe chelators plus antioxidants for better results.
That seems to be a major trend, yes. And exploring all those bioactive compounds with antioxidant or anti-inflammatory effects.
We need more human studies on those natural compounds, right, to really know if they're safe and effective.
Absolutely. Lots of promising preclinical work, but clinical trials are essential. And developing better, safer, ideally oral chelators remains a huge research priority.
So, thinking about the listener, considering these metals are just out there in the environment and our treatments still have limitations, it makes you wonder, doesn't it? Beyond just new drugs, what other kinds of approaches, maybe more interdisciplinary, involving environmental science, public health, might be crucial for preventing and managing these toxic effects in the future?
That's the big question, isn't it? It's a complex problem that needs more than just a medical solution.
Definitely something to think about. Thanks for joining us on The Deep Dive.